My side talk is about multidisciplinary care for stage 3 and resectable stage 4 melanoma. Current standard of care at the present time for stage 3 patients with lymph node metastasis and those with limited disease at distant sites, such as the skin, the lung, or other sites, is upfront surgery and then a selective use of adjuvant nodal basin irradiation, but in this case only in patients who have multiple positive lymph nodes or recurrent regional lymph nodes. This does not increase survival, but it does decrease the risk of regional metastasis recurrence. And then because of the very effective systemic agents that Professor Demidov has talked about, that we have based upon clinical trials, single agent anti-PD-1, or in patients with BRAF V600 mutations, the combination of BRAF-MEK, or because there's so many new agents and combinations, clinical trials. The same is true for patients who have had a resected stage 4 disease at a distant site. Again, it was reasonable to use either anti-PD-1, perhaps with a combination of low-dose anti-CTLA-4 in combination, or a clinical trial. And as Professor Demidov said, again, in patients with the BRAF V600 mutation, the possibility of giving targeted therapy with a combination of BRAF-MEK inhibitors. Now we need to go over why we're doing this operation. What are the goals of surgery when we're doing this for stage 3 or resectable stage 4 disease? First, we want to have durable local and regional disease control. And in some patients, this will help increase their long-term survival. And at the least, it is palliation. That is, we want to prevent symptoms of a patient in regional sites before the patient might die of distant disease at a later time. But we also want to minimize the morbidity and functional deficits with the operations that we do. And finally, we want to reduce the risk for future regional or distant failure. I want to show you in this next slide 2 examples, one in the groin and one in the axillar. These are not patients from many years ago. These are recent patients who neglected to come into their doctors. They previously had regional disease that was not controlled, but before these patients died, you can see they had a terrible quality of life because of their regional disease that was growing through the skin and causing bleeding and infection. So even if we're not increasing survival, we want to maintain regional or distant disease control when we can do this. Now, I'm not going to spend much time on surgery alone because I want to talk about the future of treatment with neoadjuvant therapy, but just some basic principles of patients who have limited stage 4 disease. That in this circumstance, surgical excision is a preferred treatment when the disease at distant sites is limited in one organ site, especially in patients who have had a disease-free interval for more than 1 year. We want to be sure that they do not have distant disease at some other site, and the key test here, after a history and physical exam, is a PET-CT scan and a brain MRI. And I think our results now with surgical treatment of stage 4 disease is better because we're doing better staging, especially with PET-CT scanning. Our goals here is not to increase survival rates because of surgery alone, but for relief of symptoms or preventing symptoms in a patient who's likely to have symptoms before they die. In those patients who have symptoms, it is more acceptable to go ahead and do surgery. For example, a patient who has obstructed bowel or bleeding from bowel metastasis These are patients where surgery might be justified. On the other hand, a patient who does not have any symptoms, such as lung metastasis, we need to be sure that surgery is safe and that we have a low risk-benefit ratio. And as we've talked about before, with so many new agents systemically, we want to put our patients into clinical trials with either systemic adjuvant treatment after surgery, or, as I will talk about next, as neoadjuvant systemic therapy with either immunotherapy or targeted therapy. Now, as Professor Demidov said, there is already 4 major randomized clinical trials demonstrating a survival benefit with either targeted therapy in patients with BRAF mutation using combinations of BRAF/MEK, or with immunotherapy with anti-PD-1, either nivolumab in the checkmate studies or pembrolizumab in the keynote studies. Actually, the keynote study on the far right is probably the best study because it was the only one that compared the pembrolizumab with a placebo. And as you can see, there was a strikingly improved survival rate, both relapse-free and overall survival. However, these are very selected patients who got into these trials because they were screened and did not have any evidence of distant disease or multiple metastasis. And so there are also patients where upfront surgery and followed by adjuvant therapy still has patients who relapse who had more advanced disease than those who were in the clinical trials. So I want to spend the next few minutes in my talk talking about the future of multidisciplinary care for both advanced stage 3 disease, stage 3B, 3C, and 3D, and resectable stage 4 disease. And in this circumstance, my main message now, both now and in the future, is going to be in these patients giving neoadjuvant systemic therapy. I was going to start out by saying the future treatment is neoadjuvant therapy, but I like this publication by the European experts, including my friend Alexander Egermont, Christian Blake, and so forth. This was published just 2 months ago, making the case that the future is now for giving neoadjuvant immunotherapy, not only in multiple tumor types, but specifically in melanoma. So I like this title because I believe this is true both now and in the immediate future. But the rules of engagement and monitoring responses to immunotherapy is different than our more classic responses with RECIST criteria in patients getting cytotoxic chemotherapy. And I want to show you 2 examples from my colleague, Dr. Merrick Ross at MD Anderson Cancer Center, who had a patient with bulky groin metastasis and pelvic metastasis who had anti-PD-1 therapy. After a few months, you could see that the masses were reduced in size, but were still present. But interesting, when Dr. Ross did a combined inguinal and iliac lymph node dissection, the masses that he saw were all chronic inflammation. There was no viable tumor. So let me give just one other example of one of Dr. Ross's patients here, an axillary metastasis. The tumor masses by CT scans were reduced in size, but at the time of surgery and pathology review, again, there was no viable tumor. So the key message here is radiological assessment is inaccurate in judging whether or not there is a true pathological complete response in these patients with getting immunotherapy, because the masses that we may be measuring on X-ray may be transformed from tumor into an inflammatory mass with scar tissue, and we cannot tell the difference between a partial response or a complete response based upon X-ray. So surgery will be a key part of staging these patients so that we know whether or not there's a pathological complete response. And if not, using the strategies that have been used effectively in breast cancer, we may need to change our therapy after surgery to some other treatment strategy. So from this article from my colleague, Dr. Jen Wargo, again in our melanoma service at MD Anderson, the advantages of neoadjuvant therapy in these patients I talked about is one, to downstage tumors and to increase the ease of surgical resection, and in doing so, reducing the morbidity of the operation itself. The second is to use pathological response as a surrogate endpoint for long-term benefit. And as I'll show you in the studies that have been done, there's a very good correlation in patients having a pathological CR have an increased survival rate. And in fact, I'll tell you several times in the published results and in our experience at MD Anderson, patients who have a pathological complete response from anti-PD-1 therapy, we have not lost a single patient who has had a pathological complete response, even after years of follow-up. So the other advantages is we can test novel combination strategies. As I'll show you, there are combinations of anti-PD-1 and anti-CTLA-4 in different doses and dose schedules, and new investigational drugs that are coming on the scene with access to surgical samples for correlative analysis. So we can tell with a immediate exposure to systemic therapy whether it works at all or whether there are resistant clones of cells for which we may need to change our therapy approach after surgery. And then we have improved response rates from studies in patients with widespread metastatic disease, since neoadjuvant patients are less likely to have been heavily pre-treated and less immunosuppressed. So it's clear that the responses of neoadjuvant therapy in patients who have not had any exposure to chemotherapy and who have more limited disease have an even higher responses than in patients with widespread metastatic disease, especially when given a second or third line therapy. Another rationale, and this again was published in Nature Medicine just a few months ago, about the rationale for using neoadjuvant checkpoint blockade. And this again is from our friends from the International Neo-Adjuvant Consortium, Georgina Long, Christian Blank, and others. So the rationale is if we do surgery and then give immunotherapy, there may be only a few clones of cells that don't boost the immune system very much. On the other hand, as shown in the lower panels, a patient who has intact tumor will have a higher tumor burden and more clones of cells, so that with neoadjuvant immunotherapy, we're likely to get a better immune response, a stronger immune response, and therefore a longer survival when immunotherapy is given up front before surgery instead of after surgery. So there's a biological rationale for this as well. Now this also is prognostic, and I want to again show you a study from the Mayo Clinic just showing the impact, the power of immunotherapy that we use today. A single dose of neoadjuvant PD-1 blockade predicting clinical outcomes in patients with resectable melanoma. This is from the Mayo Clinic, published last year in Nature Medicine, and you can see with a single dose that actually 30% of patients had a pathological response, and 10% of those had a complete response after a single dose. And as you can see, in those patients who had a PCR or a near PCR, that they had a long-term survival even out to 30 or 40 months. This is a small sample size, but compared to patients who had more viable tumor, that the survival rate was much less. So this is just an indication that the responses to immunotherapy can be prognostic in predicting survival. Now, another pilot study that again was done at MD Anderson in our multidisciplinary group led by our colleague Jennifer Wargo was in a patients who had BRAF V600 mutations who got neoadjuvant, dabrafenib, and trametinib versus standard of care before surgery. And in this study, patients who had neoadjuvant therapy, it was a small study, had a pathological complete response of 62%. And in fact, the survival rate was so great compared to the standards of care that our Data Safety Monitoring Committee closed the study because the differences were too big. So this was a pilot study, but again, in this and many other studies I'll show you, there's a direct correlation with the complete response rate and survival. Here again, you can see survival rates. No patients have been lost in that study with follow-up after 25 months. Now, this study was followed by a larger multi-institutional study led by Georgino Long, again, a neoadjuvant study in patients with BRAF V600 mutation using a combination of dabrafenib and trametinib. And I'll just give a summary, but these responses, I've been doing melanoma clinical trials for 40 years. We've never seen these kinds of pathological complete responses ever in the past, except with these new agents. But look at this, a pathological complete response in 49% of patients. That's impressive. So now I want to move on to using combinations of immunotherapy. Again, in these studies, the Opdivo Neo study of stage 3, series of papers that have been published in Lancet Oncology in the last 2 years. And this again is a phase 2 study to test different doses and dose schedules of the combination of ipilimumab and nivolumab. Now remember, in the past, we use high doses of ipilimumab, 10 milligrams per kilogram, and the toxicity was very severe. But now ipilimumab is making a comeback in combination with nivolumab at lower doses. And there is some evidence that this combination is better than either therapy as monotherapy alone. I won't go into the details of this study. This was a 3-arm phase 2 study of different doses and dose schedules of ipilimumab and nivolumab in patients with stage 3. This was all given up front. So here I have another key message. If one looks at the radiological response according to RECIST criteria, you can see that in these different dose schedules, and I'll tell you, Schedule B is the best one, so I'll focus on that. There was a 10% complete response rate and a 50% partial response rate. However, after surgery, if you look at the pathological response after surgery, 57% of patients had a pathological complete response, 7 a near PCR. So the key point here is X-ray did not predict pathological complete response. You have to do the surgery and have the pathologist looking at it. So this is a key point. Surgery is the only reliable way to stage these patients. So again, if you look at these 3 dose schedules, you can see patients who received a pathological response, very impressive, ranging from 80% to 65%. But this group B had one of the highest response rates, and in fact, the highest complete response rate, and was the least toxic. So these investigators now have gone on and used this schedule, which is 1 milligram per kilogram of ipilimumab and 3 milligrams per kilogram of nivolumab. And they published in just recently, and I'll refer you to these 2 excellent articles in the February issue of Nature Medicine, where they pulled the data from 192 patients from 6 prospective neoadjuvant trials using either immunotherapy with anti-PD-1 with or without anti-CTLA-4 or targeted therapy with BRAF/MEK inhibitors. So I would refer you to this very important 2 articles looking at pathological response and survival with immunotherapy and targeted therapy. So here are the responses that they have published, and again with 3 years of follow-up in these high-risk patients. And as you can see, overall, in patients who got all kinds of neoadjuvant therapy and targeted therapy, that the PCR, those who had a pathological complete response, 89% were alive at 24 months versus those that did not get a PCR of 48%. Very impressive differences. And then if one compared patients who got immunotherapy versus targeted therapy, and again, these are consistent results, patients in general who got immunotherapy did better and had a more durable response than patients getting targeted neoadjuvant therapy. And this is very interesting as well. If one looks at the difference between immunotherapy and targeted therapy, as you can see on the left side, patients who had a PCR out to 33 months, no patients relapsed or died. And this is our experience at MD Anderson. These are incredibly impressive results. Whereas those who did not have a PCR still at 2 years had a 72% recurrence-free survival. But if one compares giving free survival was an impressive 96%. These were all high-risk patients, not stage 3 therapy. And the key point here is the pathological response should be an early surrogate endpoint for clinical trials and a new benchmark for development and approval of new agents in melanoma. So this is one other study I wanted to show you. It's a small study, but it's a very impressive study. These are 21 patients who had unresectable metastasis with stage 3C disease using the 7th edition criteria. And after neoadjuvant therapy with BRAF/MEK inhibition, 86% of those patients were downstaged, and in 17 of the 18, an R0 resection was obtained. Remember, we started out with unresectable patients as judged by the surgeon. Also, to make the key point, none of these patients had a radiological complete response, but in fact, almost half of the patients had a PCR or a near PCR. Again, emphasizing radiological assessment is not accurate. So we have new clinical trials both in Europe and international studies that I want to encourage all of you to potentially participate in patients with advanced stage 3. This is one study, a randomized phase 2 study comparing neoadjuvant versus adjuvant pembrolizumab. This is a trial in the United States with an accrual target of 556 patients that is being accrued right now. And then this is another trial that is started in Europe as an international study, a personalized response-driven adjuvant therapy after combination of IPI and Nivo in patients with advanced stage 3 melanoma. And this is an interesting trial about surgical management. In this prospective trial, those patients who have a PCR or a near PCR after an index node resection of metastasis do not have a completion node dissection but have follow-up. And the same in this group of patients. But those who do not have a response go on and have an appropriate lymph node dissection. But the key point, although survival has not been published yet or presented, that so far in this trial, a therapeutic completion node dissection was omitted in 60% of the patients because of the effectiveness of their preoperative ipilimumab and nivolumab, again using that schedule B that I showed you earlier. So this is a paradigm shift. This is our future of melanoma management with these effective agents. that Professor Davidoff talked about in metastatic disease that we're finding are even more powerful in improving survival rate and making a major change in what we do in surgery and what operations we do. But surgery is still important for staging of these patients. So neoadjuvant strategies for advanced resectable nodal disease is a rational approach. There is no delay in systemic therapy that we would ordinarily have in patients who have upfront surgery and then adjuvant therapy. PCR, as I've showed you in multiple studies, is a surrogate for survival outcome. Combinations of strategies with these new dose schedules of low-dose ipilimumab and an anti-PD-1 actually have increased PCR rates without much increase in toxicity. And these kind of studies allow us to facilitate biomarkers, as Professor Davidoff had talked about early. And I agree with him that biomarkers are a key to our futures as well. This will also facilitate the studies of a more selective approach to lymph node dissection. It will be important for us to place clips or markers in the area of nodal metastasis so that we can remove the area where the nodal metastasis were in the first place and determine whether there was a pathological or a complete response or near. So this is my final slide. I don't believe that there is a need to wait for neoadjuvant versus adjuvant trial. As I showed you in the publication before, the future is now. But we don't have the results of these clinical trials that are being done. But so whenever that enter patients on clinical trials, especially I think these exciting neoadjuvant trials, so that we can ask a number of questions about what is the best regimen, how to minimize toxicity, the best imaging modalities. For example, PET CT scans predict responses. The results so far are not conclusive. Biomarkers for predicting PCR, and then in the end, because of effective systemic therapy, can we do less surgery in our patients, but still get the best results in terms of outcome. So I say spasibo bolshoi, and thank you for the honor of giving this presentation to my dear friends in Russia.